So today we are going to discuss the adolescent ovarian tumor, the TOG article, which is very important, and it's a long one. So we will be, again, very targeted and focused on the points of the exam perspective. At the same time, I would like to start talking about the strategy and the plan of MedExamExpert for Part 2 MRCOG. The MedExam used to customize a lot of courses, and every course has a very specific criteria. So according to the candidates, every candidate can choose the best course structure according to his or her needs. For example, the regular course or the long course, this course is over 4.5 months, and it's starting from scratch with detailed information about every module in the curriculum, helps in a structured study, giving an idea about the important topics all through among the GTGs, the BGOT, the NICE guidelines, and scientific impact papers, maybe they also the TOG articles and consent advice guidelines. So it's collectively a very rich one. If you are already well established or had a previous experience in the MRCOG exam, and you're not in need to start from scratch and to know the basics as much, you are looking for more sophisticated tips and tricks. So you can choose the progressive course, which is usually done among 8 weeks, and it's concerned about questions, how to read the question, how to analyze the data, and how to choose the correct answer. This training is mainly for people who are well established and they are looking for refining their knowledge and information. So you will find some stranges points on different points between the two courses. The progressive course, of course, we are unable to give the full information and the fine information, basics for all candidates. The time is not enough for the progressive course, but in progressive course, you will find more sophisticated questions, ideas, EMQs, single best answers, and how to manage them. So additionally, if you are concerned about only EMQs and SBAs, just pure questions, we have an EMQ, SBA, and additionally, as a new in the new course, we have EMQs, SBAs, and CTG workshops over 6 days consecutively. This is also very beneficial for those who finished the study and they are looking for practicing a lot of questions. So this is our strategy in MedExam for many years. And sometimes you may not be happy in a course because it doesn't meet your needs. That's why I'm always asking candidates to, maybe before be a part of any course, you have to tell us more about your needs, your wishes, and your level of study so that we can choose with you the most proper option to be satisfied. And of course, to pass this difficult step in MRCOG. Anyway, let's start for today's session. It's again just about
Dr. Hassan, I have a question, please. Dr. Hassan, I have a
Yes.
question, clarification. Thank you very much. Well, one more time. So what we are doing with you before now is it the regular course? And then
Yes,
I want
this
to
is the
go.
regular
Yeah, what you are
course.
doing. Okay. So the regular course, if one concentrate on it, it will be able, because I've been doing both the regular and progressive course of up to 3 times. So I don't know. What do we do? Should I concentrate on the regular course now because I have done this progressive course 2, 3 times? Still, I
You
couldn't
know,
get you.
always my advice is if you had the regular course and the broad knowledge is clear in your mind, so no need to go for other regular similar courses like that. But sometimes you may need to refine your knowledge, practicing more questions, had more ideas. So I think the other two workshops or progressive course will be more beneficial than repeat again the same information and analysis of the guidelines and something like that. So I believe it's better to go with practicing more questions, and this is will be available through both progressive course and more intensely with EMQs and CTG workshops.
Okay, lastly, you promised that you're going to take us on CTG. We complained, you said, you up to now. I hope they will still make provision for us in the record for the
Yes,
CTG.
the CTG workshop will be one of the days of the EMQs and SBA's workshop. And this session particularly will be opened to all regular course candidates.
All right, that's good. That's good. Then another
Don't
thing is
worry.
that the cost
You
of
know,
this progressive is a bit high.
my promises are very sharp. I never forget one of my promises. Don't worry.
Yeah, the progressive course is most time highly costly than even the regular. I don't know how we're going to do it. They are costly.
Oh, you know, believe me, I even don't know how much it costs. So let me revise that in the strategy of the MedExam team. And if we can do anything additional, I will be happy to offer, of course.
Please, we need help. We need help. We have done this in 3 times. We need help. We need to
100%,
succeed.
100%
Okay.
accepted.
Yes, sir. Let's go. Thank you very much. Nice man.
Thank you. Thank you. Okay. Very valid queries and questions. Thank you again. And rapidly, one of the most important things that don't try to overestimate a topic or underestimate it. So in most of TOG articles, many candidates suffered a lot in analysis of the article, summarizing the article and catch the most critical points in this article. Reading of papers is definitely more difficult than guidelines because the informations are everywhere. There are no certain points here and there you can remember, like for example in GTGs you can find executive summary, which is very beneficial, but in TOG articles there are no precise information that may help you to collectively have an idea about the topic. And that's why people somehow may be not happy to study TOGs. In adolescent ovarian cysts, I believe, just a second, please. Sorry. Yes. I believe that it's an important TOG article because the ovarian cysts in practice and as a number of cases in the real practice are really significant. And we have a green top guidelines discussing premenopausal ovarian cysts and another separate green top guideline with postmenopausal ovarian cysts. But we have no green top guideline with young age, teenager, adolescents ovarian cysts. This is the only source. So it seems to be very important to complete the serial of guidelines and informations for ovarian cysts management. It's very logic that the risk of malignancy in young age patients is very low, okay? But this is never eliminate the risk of malignancy that may happen in adolescents or even in children, maybe because of some hereditary tumors, or maybe like embryonal origin tumors. So it may happen despite it's not common. Okay. In management, generally, gynecologists should seek advice from pediatric surgeons and general surgeons, and then involving other multidisciplinary team members in the management with suspicious cases of malignancy. The first is neonatal cysts. A baby was born with a diagnosed ovarian origin cyst. The most common cause of abdominal cysts in female fetuses and neonates are mostly from ovarian origin. Sometimes such cases may be diagnosed in utero by a proper ultrasonographer, and they are mostly due to estrogen maternal hormonal fetal imbalance. Okay, so the neonatal cysts, most common cause of abdominal cysts in female, the main origin is ovarian, and main cause is estrogen maternal hormonal fetal imbalance. The management, most of cases, is conservative and may involve serial repeated scans to check the size of the cyst. Is it increasing in size or decreasing in size? Or sometimes it may be stationary, like unchanged, okay? But sometimes if the lesion is large, so the intervention is essential, as we are caring about the ovary and we are maybe suspecting torsion, ovarian torsion. In that scenario, the cysts more than 7 centimeters in diameter is really suspicious, okay? And sometimes requires urgent intervention for cystectomy to prevent possible torsion of the ovary, and then saving the capacity of the ovary for the neonate. Let's check the you can see the screen, Yasmin. I think the screen is clear to most of people, am I right? Or this is a common problem? Everyone, can you see the screen, please?
Yes, sir.
Yes. Okay. Yes, okay. So if you have any problems with voice or screen, you can just relog again. Thank you. Okay. And then we need to just revise rapidly the different terms and classification of ovarian tumors, the benign and possibly malignant tumors. So in neonates and in teenagers, adolescents, all of this group of age, the benign are the majority, as simple cysts counts about 60% of cases in practice. Sometimes we may have a complex cyst by ultrasound scan, and this complex cyst may be a teratoma, sometimes endometrioma, despite it's very rare, sometimes mucinous or serous cystadenoma. Ovarian torsion and tubo-ovarian abscess, both may happen as well in young age patients, and they are both associated with pain, both associated with temperature, both associated with changes in blood tests like increased TLC, increased CRP, but tubo-ovarian abscess is dramatically associated with high-grade fever, while the ovarian torsion is characteristically associated with periodic unilateral pain. Periodic unilateral pain. It means that in ovarian torsion, it's very characteristic that the pain is on and off. So it's not continuous pain like tubal ovarian abscess, but it's on and off. If the ovarian pedicle start to twist, the pain starts. When the twisting stops, the pain is vanished, and then it's maybe happen again. So the on and off criteria of pain and tenderness is characteristic with ovarian torsion, while the pain and tenderness in tubal ovarian abscess is continuous. The second difference is the fever. In tubal ovarian abscess, there is a significant high temperature, more than 38.5, while in ovarian torsion, it's a low-grade fever with temperature not more than 38. And finally, CRP, CBC, I mean complete blood pressure, the TLC changes are common changes in both of them. On the level of malignancy, which about 15% of cases of adolescent ovarian lesions, the 6-cord tumors and germ cell tumors carries the higher rates in comparison to epithelial tumors. This is definitely the opposite in comparison to premenopausal or postmenopausal women. The 6-cord and germ cell tumors are more common in adolescence age and less common definitely in pre and postmenopausal women, while epithelial tumors are 90% of ovarian lesions in pre and postmenopausal women, not less than 25% in young age patients. The 6-cord tumors and germ cell tumors seems logic because they are either related to puberty or related to embryonal origin tumors. So, of complex benign cysts, germ cell tumors are the most common in children and adolescents, with up to 70% of them will be mature teratomas. Okay, these information are critically common in SBAs, so take care. And then with mature teratomas, there is a spontaneous risk of rupture, and then it's count about 1%, and then there will be a very famous condition called pseudomyxoma proteinii if the spontaneous rupture of dermoid teratomas happened. The malignant transformation is about 2% with possibility for stroma ovarii or carcinoid tumors. Both of them are extremely rare. And then the carcinoid tumor may be related also to appendicular associated lesion, the appendicular appendix tumor. And the stroma ovarii is characterized by production of different hormones like thyroid hormones, for example, from the ovary. Yes, from the ovary. Okay, so they are extremely strange tumors. In the germ cell tumors, although benign lesions are common, but it can evolve into a dysgerminoma as well with malignant features. The dysgerminoma may be considered one of the most common germ cell tumors. And we have some information regarding the dysgerminoma. I will tell you about the tumor markers. And you know, all ovarian tumors are radio resistant. That's why we have no radiotherapy to ovarian lesions except the dysgerminoma. This is the only one that is sensitive to radiotherapy. However, you know why we are not using the radiotherapy directly with the dysgerminoma? Because of the ovarian reserve. In young age patients, we are really keen about the ovarian reserve as a part of fertility preservation. This is one of the major challenges in young age adolescent tumors, how to keep their fertility options and how to give them the chance to be a mother one day. That's why we are just dealing with chemotherapeutic agents rather than the radiotherapy in dysgerminoma. What about the malignant ovarian tumors in adolescence? Almost half of malignant tumors in children and adolescents are juvenile granulosa cell tumor. Let's stop a little bit. How can we diagnose granulosa cell tumor in exam? The granulosa cells are responsible for estrogen production from the ovary, as well as we have different sources of estrogen in the body, but the majority of estrogen in the body is formed in granulosa cells of the ovary. Then the granulosa tumors, we have an excess production of estrogen. This excess production of estrogen will be reflected on the patient as endometrial thickness and abnormal vaginal bleeding. This is very critical. So if you have a patient, she is young age, child or in adolescence age, and she started irregular vaginal bleeding heavily, heavy menstrual bleeding or irregular bleeding through the month. The patient had ultrasound scan, showed endometrial thickness, and there is an associated ovarian lesion. This is simply a classic picture of granulosa cell tumor. Additionally, if you have a scenario, for example, with a patient, she had abdominal distension and precocious puberty, you have to think about granulosa cell tumor. Is that common? No, it is not. But it's very tricky in the exam. A girl, 7 years, maximum 8 years, with secondary sex characters well developed, start vaginal bleeding, and a picture of cafe au lait patches, precocious puberty. And then the patient had a very strange abdominal distension and bloating. This is a very critical landmark about ovarian lesions. So you can connect information together. An ovarian lesion, estrogen production lesion, precocious puberty. This is a case of granulosa cell tumor. On the other hand, if you have a patient with postmenopausal bleeding, endometrial thickness more than 4 millimeters, and associated with ovarian lesion, this is granulosa cell tumor till proof otherwise. So just be open-minded and try to broadly think about the diagnoses of granulosa cell tumor. They are mainly estrogen-secreting tumors, but sometimes a germ cell tumor, a sex-cord tumor, may be androgen-secreting tumor. Androgen-secreting tumor, like Sertoli-Lige cell tumor. This androgen-producing tumor will lead in young adolescents, females, to clitoral enlargement, hirsutism, deepening of voice, and definitely irregular periods up to amenorrhea. So this diagnosis is, very similar somehow to young age PCOS. I'm right. It looks like the same in the exam. If you have a patient, a young girl with hirsutism, irregular periods, or up to amenorrhea, you will think directly in PCOS. This is the most common. This is the most common scenario. But to differentiate PCOS from androgen secreting tumors, clinically, deepening of voice is one of the most critical clinical differences between androgen secreting tumors and PCOS, because deepening voice depends mainly on the amount of androgen production, which is significant amount in androgen secreting tumors, and it's a little bit in PCOS. If you would like to confirm your diagnosis with an investigation, so the testosterone level, the serum testosterone level will be the best option to differentiate PCOS from androgen secreting tumors. Just to remember, from 0 to 2 nanogram per liter androgen, this is normal in women. More than 2 or equal to and less than 5, this is PCOS. And more than 5 nanogram per liter or equal, this is definitely a problem with androgen production. This is maybe androgen secreting tumor, or in young age, what it could be. Anybody would like to share information with me? What is coming to your mind when we have a high titer of androgen in young age patient? What it could be?
Congenital adrenal hyperplasia.
Thank you. Late onset congenital adrenal hyperplasia. That's great. Excellent, Aisha. Thank you so much. So let's do another graph. Let's do another graph. Just a second. If you have more than 5 testosterone, my options are maybe congenital adrenal hyperplasia, late onset, or androgen secreting tumor. Am I right? So what is next? I believe 17th hydroxyprogesterone in urine is my next investigation. 17th hydroxyprogesterone in urine will be my next investigation. If it's high, this is a congenital adrenal hyperplasia. If it's low or absent, then I have to investigate more the possibility of androgen secreting tumors. So for androgen secreting tumors, it could be either ovarian in origin from theca cells, or adrenal in origin. How can we differentiate between both of them? Choose a test for me, please. We need a test. Now, I have a very critical test, the DEHIA-S. The DEHIA-S is the best test to differentiate between adrenal origin and or ovarian origin androgen secreting tumor. If the DEHIA-S is high, so simply this is adrenal in origin. If it's normal or low, it will be ovarian in origin. This is how can you discuss the differential diagnosis of a girl with hirsutism, amenorrhea, or irregular periods. This is how you can think in the exam. Just to clarify this point, if you have same symptoms, but in post-menopausal woman, a patient post-menopausal, she had deepening of voice, hirsutism, what do you think she may have? She may have androgen secreting tumor or any other option? Anything in differential diagnosis?
Ovarian hypertrichosis.
Ovarian hypertrichosis. Thank you so much. There is no ovarian hypertrichosis in young and premenopausal women. It's an exclusive finding.
Oh, sorry, I thought you were talking about postmenopausal.
Yes, it's exclusive to postmenopausal and old age patient. When the theca cells start to regain activity alone and secreting more androgens. So we have then two options again, androgen secreting tumor, exactly like the premenopausal and young age patients, and ovarian hypertrichosis. Now, one of the most critical points in the scenarios in the exam to differentiate both of them without any investigations is the onset, course, and duration of hyperandrogenism. In the androgen secreting tumors, the hyperandrogenism takes very short time. Changes will happen in a very rapid course. But in ovarian hypertrichosis, changes will take more time, more than 6 months typically, and the deterioration of symptoms takes longer time than androgen sensitive secreting tumors. This is very critical. When you have a scenario that the patient in just 3 months start to have a significant changes in hair growth in face and chest and deepening of her voice, so you have to think about androgen secreting tumors. While if these changes happen over 2 years, this is mostly ovarian hypertrichosis. That's it. So this is all you need to know about the germ cell tumors and 6 core tumors, either in young age patient or in older one. Okay. Just to remember a point about a precocious puberty. If you have a young age patient, less than 8 years, and she start to show puberty signs, then we have to think about a disease known as precocious puberty. One of the causes of precocious puberty is estrogen secreting tumors. It could be ovarian causes like estrogen secreting tumors, granulosa cell, or sometimes an androblastoma. It secretes both androgen and estrogen tumors. Sometimes the estrogen source may be from the adrenal gland, and otherwise it could be central causes, central CNS pathology like CNS tumors, or congenital diseases like hydrocephalus, any stimulant to the CNS system like irradiation, trauma, or infection, and maybe familial or some diseases running in the family. It means like genetic. In the peripheral causes, we are always thinking about the estrogen secreting tumors. And then all of you remember very well the McCone-Albright syndrome, a picture of secondary 6 characters very well developed with vaginal bleeding, and the patient had bone cysts and skin patches. Bone cysts and skin patches. I'm always remembering that. This is for me, I mean. C, McCone. We have C, cysts in the bone. We have another C, cafe au lait patches. And we have precocious secondary 6 characters criteria. So McCone Albright is characterized by 3 C's. 3 C's. Cysts in the bone, cafe au lait skin patches, criteria, secondary 6 criteria for a young girl less than 8 years old. So this is just a brainstorming regarding the precocious puberty in those patients. Now, the next is possibly tubo-ovarian abscess. And it's extremely rare to find a tubo-ovarian abscess in a young age or adolescent patient, unless in the exam, if you have the same scenario, believe me, you don't have any options rather than sexual abuse. The patient should have a sexual activity, unprotected intercourse, and then she catch the infection, the PID, the tubo-ovarian abscess. This is the regular sequence of events of tubo-ovarian abscess in adolescence. Otherwise, don't choose tubo-ovarian abscess in the exam, because most probably there is no reason for tubo-ovarian abscess after a PID untreated case in adolescence if she has no sexual activity. Sometimes I will write them. Just a second, please. Cysts in the bone, cafe or the patches in the skin. Thank you. We are written already in the chat room. Okay. So it's very important at that point with tubo-ovarian abscess, particularly in the exam, in adolescence, to think about sexual abuse risk, maybe how to utilize this information. I mean, for example, if you have a scenario with a patient, she is 12 years old, for example, she came to the E&E with severe abdominal pain and tenderness, vomiting, and she is feverish. She is feverish. She denied any bad food or something, and she denied any medications or drugs. What is the most appropriate next step in her management? Any suggestions? Try to think. If you have this scenario in your practice, what would you like to do? Please, everyone, ensure that your mics are closed. Okay. Let's see the suggestion. Ultrasound scan. Oh, ultrasound. Okay. Okay. All of you are still thinking as a doctor, which is great. Which is great thing. But in exam and in practice in UK, you have to think a little bit from the patient safety and your safety point of view. Do you know when we had a case in A&E with fever, significant fever, what we used to do first? Isolation. Isolation. This is very important tip in the exam. If you have a case with fever, for example, if you have a patient, she had a honeymoon in Africa or in Asia or whatever, and she came back with fever, vomiting, blah, blah, blah. The most common is gastroenteritis. I believe in that. But actually, she may be malaria patient. She may be leishmaniasis patient and all of this stuff. So isolation of feverish patient in exam is critical. If you have this option, go for isolation first. And then you can think about abdominal examination. Examination is very critical. Why? Because we are going through a systematic approach. I can't jump from history taking to ultrasound scan bypassing examination. So we are usually going with history taking, proper examination, offering investigations, and then plan of management. This is the systematic approach thinking. So if I have an option of clinical examination and pelvic abdominal examination, I will choose this. And then I can think about investigations. The most important blood test is full blood count, looking for TLC. If I have further options, I can go with abdominal ultrasound scan, looking for any ovarian event. And then I can put a plan of care. Now, in clinical examination, if you have some suspicious regarding sexual abuse or unprotected intercourse against the patient's willing, then the most critical choice is clinical examination, looking for any bruises, any scratches in the skin, and any trauma to the genital area. So this is very, very important in exam. The question may be like tubo-ovarian abscess, apparently like tubo-ovarian abscess, but actually this is a case of sexual harassment and sexual abuse. So I need the clinical examination as the most important step after isolation of the patient because of her fever. This is how questions in EMQs regarding tubo-ovarian abscess in adolescent patient may be in your exam. After the tubo-ovarian abscess, we may have a scenario with a torsion, and the torsion incidence is high. It's almost maybe 10% of ovarian cysts lesions in adolescents may have an ovarian torsion. The main age is too young, is maybe 10, 11 years. And it's more common on the right side. Do you know why? Is it common on the right or the left side? On the right side. Do you know why? Because the left side is occupied by sigmoid colon. Okay, the left side is occupied by sigmoid colon. Okay, simply. Excellent, Lakshmi. Thank you so much. I am happy because you are thinking very well. Now, patients are likely to experience a longer duration of pains, and it's like colicky pain on and off. The diagnosis is very difficult, especially in children, because they are unable to fully prescribe their complaint. And maybe the differential diagnosis, including appendicitis on the right side, urinary infection, constipation, volvulus and intussusception, and ureteric problems like ureteric stone or something like that, which is not that common in young age patients. But this is the differential diagnosis. What is the management? Once the diagnosis is established by ovarian Doppler studies, confirms shutting down the blood flow, now this is an urgent case of ovarian artery torsion, and the patient should be offered detorsion laparoscopic detorsion plus or minus fixation of the ovary to prevent future torsion one more time. Oophorectomy, sir, surgical. Sir, kindly repeat why common on the right side, because the left side is occupied, the left iliac fossa is occupied by the sigmoid colon. So the range of torsion on the left side is definitely less than the wide spaced right side. So the treatment, one more time, is not oophorectomy. It's not cystectomy at the same set of torsion. It's just like detorsion laparoscopically and plus or minus ovarian fixation to prevent further future torsion attack at gains. Please remember that torsion is not a complaint of young age adolescents only. The most common de novo torsion happens in young age adolescents. This is maybe because of congenital long mesotubo-ovarian ligaments, congenitally. But the most common cause of torsion in in childbearing period is large ovarian cyst. The second most common cause is ovarian hyperstimulation syndrome. Both of them are uncommon typically in adolescence. In the adolescence, the most common is congenital long tubo-ovarian ligament for torsion. Okay. So the presentations of the torsion may be asymptomatic or incidental. This is very common. Pain on and off, colicky pain, is very common. It's extremely rare to represent with abdominal distension or abdominal mass or any other symptoms like menorrhagia, like weight loss, like dysuria or leg pain, fever, nausea, vomiting, back pain, all of them very common to be seen with ovarian torsion. This is exactly the differential with tubo-ovarian abscess. Same picture, but please remember what we said regarding the fever. It's just low grade. The vomiting attack with pain due to peritoneal irritation, as well as the back pain. How can we investigate ovarian lesions in adolescence? How can we check the differential diagnosis and differentiate lesions? The transabdominal ultrasound scan is performed in children and adolescents with full bladder view to increase our chances for proper identification of ovarian lesions. It's helpful for differentiating benign from malignant lesions, maybe according to IOTA criteria, which all of you knows that very well. If the cyst or the lesion is complex, the ultrasound scan can be confirmed with MRI. Now, the MRI here is critically important to know the nature of the ovarian lesion. Please remember that in older patients, if we have a query, high-risk ovarian lesion with RMI more than 200, we usually are requesting CT scan, am I right? CT abdomen and pelvis. But in ovarian lesions in adolescence, to confirm the nature of the mass, MRI is recommended, not the CT scan. And this is one of the major differences in management plan between adolescents in exam and childbearing period or postmenopausal women with suspicious ovarian lesion. Is that clear? If you need to remember that, please revise the flow chart in GTG 34, postmenopausal ovarian cysts management, in the last paper of the guideline. Please revise the flow chart very well. You will understand what I say about the CT use versus MRI use. So against all our rules, CT scan should be offered to ovarian lesions. This is the rule. But MRI for adolescents should be offered. This is the changing rules according to the age of the patient. So we go for postmenopausal women, we go CT, and in adolescents go for MRI. I like your summaries. Thank you. Yes, this is exactly the point. Last thing, to complete the full picture of investigations, you need to remember some tumor markers, which are very important, like alpha-fetoprotein with most of germ cell tumors, human chorionic gonadotrophin with embryonal carcinoma and choriocarcinoma as well. LDH is a very important landmark for dysgerminoma and teratoma. Then CA125 with, this is the cornerstone tumor marker in epithelial origin tumors. Sometimes chorioembryonic antigen may be also increased with epithelial tumors, and definitely estradiol is the landmark tumor markers for granulosa cell tumor, and testosterone for androgen secreting sertoli cell tumor. Now, how to manage? It's very simple. If you have a patient confirmed with ovarian cysts, it depends on, is it symptomatic or accidentally discovered, asymptomatic patient. So if she's asymptomatic, it means there is no pain, or she had a mild pain in the abdomen, some menstrual changes, or precocious puberty changes. Please offer transabdominal ultrasound to the patient. And accordingly, if we have a simple cyst less than 5 centimeters, we can just discharge the patient and reassure her. If we have a simple cyst, 5 to 7 centimeters, if the patient is asymptomatic completely, we can offer her a rescan in 3 months. It could be resolved spontaneously, so I can discharge her. Or it could be persistent or increasing in size, so I will take further step. And if it's from 5 to 7 centimeters and it's symptomatic from the start, I will take this step. Which step is, I will do the MRI and tumor markers. Very simple. I will do the MRI and tumor markers, the investigations we discussed before. And then according to the results, I can build up an opinion if I need to remove this lesion or I can keep eyes on it. But definitely, if the lesion is more than 7 centimeters, I will bypass the conservative management. I have to put it there. I need to do the MRI and tumor markers, of course, and go directly to remove the ovarian lesion. Laparoscopic ovarian cystectomy is the ideal option for those patients. Why more than 7 centimeters I need to do an intervention? Because I have 2 situations I need to ensure that they will never happen. rupture of the cyst, which may lead later on to pseudomyxoma proteinii, for example, and ovarian torsion, of course. Now, if we have an emergency condition, a patient to the A&E, coming to the A&E with acute abdomen, suspected tube ovarian abscess, suspected torsion, suspected rupture of a huge ovarian cyst or something, imaging to inform surgery if available within 4 hours of admission and clinical condition only. This is the indication for imaging in this situation, and then laparoscopic surgery, where possible, ovarian sparing surgery should be done. Now, please remember that if we have a complex cyst and tumor markers, MRI, of course, requested, if there are no suspicions, I mean low risk patient to have a cancer, then we can offer laparoscopic cystectomy for the patient. And if, of course, we have a risk of high cancer possibility, so we need to offer urgent referral to tertiary cancer center in 2 weeks escalation pathway maximally to be admitted there under the supervision of multidisciplinary team. Torsion rupture. Thank you, Salam. Sir, after 7 millimeters, 10, go for cystectomy, not oophorectomy. If adhesions are present, then what to do? We are trying to do our best for fertility preservation. So that's why we are going to cystectomy, not oophorectomy. Adhesions, unpredictable bleeding, life-saving situations, highly suspected malignancy against all investigations, intraoperative, all of them, we need to do oophorectomy, okay? Please don't forget that any woman in UK are in practice opted for cystectomy, she is already informed and consented for possible oophorectomy in certain situations. So it is not a problem, by the way, if there is adhesions or other reason requires urgent oophorectomy, but this is not the rule. Okay, Sobia? Is the plan is clear in all your minds?
Excuse me, sir.
Yes, Amper?
Sir, in simple cyst greater than 7 centimeter, in box it's written that rescan in 3 months can be considered if asymptomatic. Please explain this point according to exam point of view.
Okay, you can see here, you have two options. If we you are talking about this one. Okay. Rescan in 3 months be considered if asymptomatic. You can see here when the simple cyst, this box, they didn't give you options. Is it symptomatic or asymptomatic? We are trying to offer directly an intervention, but maybe rescan and follow-up may be offered if the patient is asymptomatic. From the perspective of the exam, if there is no clear boxes, routes for asymptomatic and symptomatic, and the arrow takes you directly to the box of management, it means the conservative option is consultant opinion in this scenario. It's a consultant opinion. So you cannot use this option in exam, and then as a trainee, you have to offer the ideal first line option, which is surgical removal. Please apply the same idea on the previous box. So simply, if you have a simple cyst 5 to 7 centimeters, it's here divided into two small boxes, asymptomatic or symptomatic. It means it is not a consultant opinion. If the patient is asymptomatic, to offer her rescan. This is the rule. And it's not a consultant opinion. If she is symptomatic, to offer her tumor markers and MRI. You have to follow the tracks. It's completely different in this one. In this one, the box takes you directly to the management plan. There are no differences between symptomatic and asymptomatic. But in few cases, you can offer conservative management if the patient is asymptomatic. Can I do that? No, this is a consultant opinion. So this is not a choice in the exam. Am I clear?
Thank you, sir. Thank you so much.
Thank you. And then next, just to summarize, with laparoscopic ovarian cystectomy, especially for mature teratomas, the main risk intraoperative is a cyst rupture. And this is typically may lead to spillage of the contents in the peritoneum, leads later on to chemical peritonitis and adhesion formation. So we need to ensure the excision of the teratoma intraoperatively without any spillage. In modern practice, we are doing such surgeries by using something called endobag, okay, to ensure there is no spillage even if there is an injury or a cut in the cyst during extraction. If adnexal torsion is suspected, prompt investigation and intervention is required to avoid long-term damage of the ovary. Now, the current practice recommends only detorsion with or without cystectomy according to the consultant vision, even if the ovary looks necrotic. So don't do oophorectomy, whatever the situation is. Detorsion is enough. In suspected malignancy, it's crucial for gynecological oncologists and pediatric oncologist surgeon to be involved in the multidisciplinary team discussions. We did it. This is the TOG article, Adolescence Ovarian Lesions Management. I think we summarized it in a very small bullets just to be remembered. Some of these bullets will be in the form of SBAs, like what is the most common, blah, 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 what is the least risky, and all of these stuff. Others will be definitely in EMQs, and I think we put a plan to manage every single scenario in adolescence patients with ovarian lesions. Any questions?
Yes, sir. Thank you very much. That was a good one, Dr. Hassan. My question is, what we have just treated is just for the adolescent, correct? And we didn't do much on the post and premenopausal. That could be taken some other time, I suppose. So in summary, what you're trying to tell us is that the size is what determines what we do. First and foremost, we need to know the size, and that will determine whether we are reassuring, whether we are rescanning, and whether we are undergoing laparoscopic cystectomy, correct? That's exactly what I wanted to get clear, unlike in the case of postmenopausal and all that, where you talk about 1 cm and you go ahead and do. I just want to get that clear in my mind. Thank you very much.
Yes. Now, you said a very important thing when you decided that we are building our idea in management according to the lesion size. It's, of course, one of the parameters that we need to ensure before starting our plan of management. So the centimeters diameter of each lesion plays a role in our decision, but we have many other factors that may be affecting our decision. For example, if you have, number one, it depends on which age group the patient is. Is it adolescent or premenopausal or postmenopausal? In adolescents and premenopausal women, premenopausal women, they are mostly sharing the same sizes and management plan accordingly. So before 5 centimeters, from 5 to 7, and more than 7, the same plan most commonly. Expect the investigation tools. And then in postmenopausal women, she is different. In postmenopausal, starting from 1 centimeter diameter ovarian cyst, we should take our precautions and start to calculate the RMI. The RMI. On the other hand, because of some difficulties in doing the perfect ultrasound scan, which is the transvaginal ultrasound scan in young patients and adolescents, and then we need to add additional imaging tool like MRI, which is not necessarily to be used in other women when the transvaginal ultrasound can be used and can be done easily. This is a philosophy of management, why we choose this and why we neglect using this in other patients. I always say this is a customized plan of care, and this is the medicine. There is no guidelines. I can't say that because it's against the policy, but actually guidelines are there to help people about knowing the basics. But in the real exam scenarios and in real questions and real practice in your life later on, you will discover the fact that I can't apply the same guideline for all patients. Okay. Every patient, you should tailor her treatment plan according to her symptoms, according to her family history, weight, physical, medical, surgical, all of these histories. You have to customize and tailoring a certain treatment plan. So I agree with you, the size of the cyst is very important, but we have many other important factors that may affect our decision according to the patient's age group, the nature of ovarian cyst. Is it simple, complex, highly suspicious malignancy? The tumor markers, the proper imaging tools. So all of them together can help you to reach a proper diagnosis. Actually, to summarize all of this, I need from all of you to ask yourself one question when you are reading any scenario related to ovarian lesion. Any scenario. Is this patient high risk to be malignant or low risk? This is more than enough. If she's a high risk, take the steps of high risk patient, like urgent referral, like further imaging tool, like MDT involvement. If she is low risk, then you can think about conservative management, laparoscopic cystectomy, and all of this stuff. This is simply, what is the risk to be malignant? This is the most important question to be answered. Can you explain the differences? Oh, just a second, I didn't read the question. Can you explain the differences of ultrasound picture of different types of cysts? Oh, yes, I can. If you're asking me, I can. Okay. I will show you a very important slide from one of my lectures in conferences. Give me 1 minute. I will be back. I will answer other questions, but I will be back with this slide. Give me 1 minute. Yasmin said, sir, can you please conduct more free webinars? Yes, I like that. I will do. If you are happy with that, I will, of course. For adults,
so we'll be
to avoid
expecting
rupture
the CTG
of
very soon.
teratoma during operation, we do open surgery. but in adolescence, can we do open surgery? You can do open surgery with any patient, but we prefer to go with laparoscopic surgery because it's maybe later on associated with less pain and less adhesions formation. However, if you in your practice, if you don't have an expertise or a proper instruments for laparoscopy, you can definitely go for open surgery if the open surgery is safer to the patient than laparoscopic surgery. Please don't go anywhere. I will be back in 30 seconds. I will just show you a picture I need you to see just to remember. Ah, yes, this one. It's a great one. Okay, just a second. Yes, this is the slideshow. Okay, just to remember, this picture is summarizing the aorta classification. The aorta classification, okay? The B criteria, the benign criteria, it should be unilocular lesion. Unilocular lesion, okay? It should be, if it contains any solid components, it should be less than 7 millimeters in diameters, okay? And then there can be some acoustic shadowings, and if the borders are very smooth and regular outlines, and there are no blood flow in Doppler studies involving the lesion itself. This flow is outside the lesion. Now look at this. Now this is a very strong blood flow inside the lesion itself. Now this is a high risk lesion to be malignant. Now this is irregular, solid, multilocular tumor, huge size, mostly more than 10 centimeters. This is highly suspicious to be malignant. If you have more than 4 papillary projections inside the lesion, 1, 2, 3, 4, maybe 5, okay? So this is highly suspicious for being malignant. If you have an ascites, free pelvic collection in the Douglas pouch or higher, this is very high risk to be malignant. And of course, solid lesions are highly suggestive of malignancy in comparison to cystic lesions. The B and M criteria, benign and malignant criteria of aorta classification. Just remember the pictures. This you may find in your life because they are from practice. These pictures are from practice, by the way. So, is it clear, Salam? Is it clear right now in your mind? I wish that. Please tell us about McCone-Albright syndrome. I have nothing to say in McCone-Albright syndrome rather than a patient with precocious puberty, less than 8 years old, because this is the definition of precocious puberty. And this patient is characteristically associated with typical secondary sex characters, vaginal bleeding, bone cysts, and skin patches, a whitish skin patches, all together is known as McCone-Albright syndrome. Tumor marker option of course, the treatment simply in McCone Albright is Zoladex, GnRH analogs. Tumor marker option in adolescence, alpha fetoprotein, HCG, LDH. Okay, tumor markers in adolescence, it's equal to tumor markers of premenopausal women. CA125, LDH, alpha fetoprotein, HCG, unless the patient has hyperestrogenic or hyperandrogenic symptoms, then estradiol and testosterone should be also requested accordingly. Okay, so the most important point for malignant is vascularity or capillary vascularity. Vascularity is fatal, 100%. What is the percentage of these tumors in UK? Now, overall ovarian malignancy incidence among population in UK is 1.7%. You can say 2%. 2% is a huge number, by the way. But your question is not accurate, Najla, because what is the percentage of tumors, ovarian tumors, among positive family history and BRCA 1 or 2 positive patient? It's almost 30% in BRCA BRCA 1. Okay, maybe up to 45%, and in BRCA 2 up to 20%. Now the number is completely changed. But among population with no genetic predisposing factors, it's 1.7%. Tell us the histologic appearance of different types of tumors. Why? Why you are asking such question? I'm not a histopathologist, Sylvia, but simply it seems like we have some important landmarks in each tumor. Okay, so for example, I will show you another thing. Okay, I will show you in a minute. Give me 1 minute. Okay, just to take it like a photo, and keep it in your bank of answers. I mean, I know what you mean. You mean the Semmoma bodies, the Kohl-Zener tumors, the hobnail appearance. Do you mean that? I think so. Kohl-Zener in granulosa cell tumor, hobnail in clear cell carcinoma, Semmoma bodies in serous carcinoma, Roktanesky nodules in teratoma. I will show you the table right now. This is very easy to be remembered. Retenki's crystals in light cell tumor. Let's see where is it? Where is it? MOX, maybe? Yes, MOX. Questions on co. Yes, I think so. It will be here. Yes, this one. I like that. Take it. This is the slideshow from the current slide. These serous epithelial tumors are characterized by Semmoma bodies, clear cell tumor with hobnail cells, Brenner tumor, which is epithelial in origin, but it's benign, Walt-Hard cell nests, not rests, nests. Large polygonal cells, teratoma is characterized by ecto, meso, and endodermal origin cells known as Roktanesky nodules. Roktanesky nodules. In endodermal sinus tumor, the germ cell tumor of the ovary, Schiller-Duval bodies are there, Zener bodies with granulosa cell tumor and Rinke's crystals with Leitch Sertoli cell tumor, signet ring appearance cells in Krukenberg secondary malignant tumors. I wish that this point what you are looking for. I wish. Yes.
Sir. Excuse me, sir.
Yes.
As a teenager is sexually active, we will go for TPS or TAS.
Sorry?
Somebody's out.
Sir, if in
Yeah, my
scenario,
man.
teenager
Yeah,
is
ask
sexually
your question. Teenager is if she is sexually active, can we do a transvaginal ultrasound? Is this your question?
yes, sir.
Of course, yes. If you have a choice to do the transvaginal ultrasound, go for it, because this is the most accurate, and I mean the most recommended primary imaging tool for assessing ovaries. So if she is sexually active and regularly sexually active, we can do the vaginal ultrasound scan to a teenager or an adolescent.
Thank you, sir. So one more question. In that scenario, there was a history of a adolescent in which we proceed for a surgery. So they mention in scenario that there is history of appendectomy before. So we will choose laparoscopy or laparotomy.
Now, simply to finalize this argument, in exam, laparoscopy should be chosen in the following scenarios. Diagnostic laparoscopy in infertility, any tubal surgery, salpingectomy, or tubal disconnection should be done by laparoscopy. Ovarian cysts, which are mostly benign, should be done by laparoscopy, laparoscopic ovarian cystectomy. Ectopic pregnancy should be done by laparoscopy if the patient is vitally stable, non-urgent condition. So in these 5 scenarios, we can go with laparoscopy. Otherwise, any procedure, choose laparotomy. Hysterectomy, which is better in exam? In exam, laparoscopic hysterectomy or total abdominal hysterectomy? Total abdominal. We are choosing the default procedure, not the best procedure. This is a huge difference. Which is better? Theoretically, which is better? Abdominal Birch colposuspension or laparoscopic Birch? Laparoscopic Birch is very easy, okay? And the patient's recovery is wonderful. Easy for a surgeon and easy for the patient. So it's the best. But for exam, I will go with open colposuspension, Birch colposuspension. Why? Because this is the default procedure. You are in a hospital, Amper, am I right? You are working in a hospital, am I right?
Yes, sir.
How much people in your department can do laparoscopic Birch perfectly or laparoscopic colpopexy? Frankly.
No one, sir. Frankly speaking.
Yes, this is the game. This is the game. So any advanced procedure requires expertise or requires many other things in instruments, situation, expertise, and all of this stuff. You cannot choose easily in the exam. So if you are looking for a hysterectomy, go for total abdominal hysterectomy. I know people.
Sorry, Dr. Hassan. Sorry,
Sir,
Dr. Hassan.
excuse me, I want to ask a
For
question,
the
sir.
hysterectomy,
Excuse me, sir.
we are going to, hello, for the abdominal hysterectomy, is it laparoscopy or laparotomy? Can you hear me, sir?
What is the default procedure? What is the basic procedure?
Laparoscopy.
Laparoscopy is the basic procedure for hysterectomy? Do you think so?
No, laparotomy.
Exactly. So we are choosing the basic procedure. Let me ask you another question. If you have a patient, you need to do a hysterectomy for this patient, and you have 3 options in the exam: abdominal hysterectomy, laparoscopic hysterectomy, robotic hysterectomy. I will
use abdominal laparoscopy.
Exactly. If you are looking for the best of best, I will choose robotic. But actually, I'm not looking for the
Sir,
best of best because this is not the default. The basic should be chosen in this exam. Otherwise, you can negotiate in your practice. But in exam, we are very stuck to the basics. Yes, Sobia, ask your question.
sir, I want to ask that in cases while we are reading the guideline in premenopausal ovarian complexes or any says that having an atypia, we can go for laparoscopic TH, right? We are not going for laparotomy TH in case of premenopausal women that having a complexes with atypia.
Now let me explain again your question. A patient had an ovarian problem, am I right?
Yes, sir.
Why you are going to do hysterectomy?
Sir, in cases of premenopausal women that having endometrial hyperplasia with atypia, we can go for laparoscopic hysterectomy in premenopausal women, right?
So why not in postmenopausal?
Sir, postmenopausal guideline says that we are going for total abdominal hysterectomy with bilateral salpingo-oophorectomy. But in cases of premenopausal women, we can go through a laparoscopic approach.
What is the difference between premenopausal and postmenopausal if she is low risk with endometrial hyperplasia? It's not a cancer. So what is the difference between the patient here and patient here so that I choose laparoscopy here and laparotomy here? I can't understand. If the laparoscopy, by the way, I can do laparoscopy in postmenopausal, in premenopausal. I can do laparoscopy in oncology or in benign lesion. I can do radical hysterectomy by laparoscopy. I can do staging laparotomy by laparoscopy. I can do anything by laparoscopy. It's not related to the nature of the disease or the nature of the patient. It's related to the idea of, in exam, we are dealing with basics. Basic surgery should be chosen in the exam. Let me ask you a very simple question and giving all of you a very simple example. If you have an ectopic pregnancy undisturbed, can I do it by laparotomy? Of course, yes. But what is the basic recommended widely spread procedure? Laparoscopy. So I will choose the easy, recommended, basic, widely spread procedure, laparoscopy. Now, is it if the ectopic pregnancy is disturbed with internal hemorrhage? What will be my choice?
Laparotomy.
Why?
Laparotomy.
You know, your answer is correct. Why? Because with emergency condition, I have to go with laparotomy. While myself, I never had a laparotomy for disturbed ectopic in the last 4 years. I'm doing it by laparoscopy. It's easier, more rapid. I can just get inside, suction all of the blood here and there, putting the ligature. In 2 minutes, I finish the situation. I can do the laparoscopy in unstable patient, but I can't apply this in exam because automatically all of you and all people knows that In emergency bleeding case, go for a laparotomy. This is the basic procedure. And this is what I am looking for in the exam from the candidate. I'm not looking for shooting to the moon answer. I'm looking for a standard answer. Ooh, I wish I was able to convince you, Sobia. I wish, because I know you are
Okay,
very smart. And your
thank you,
questions
sir.
are very challenging, my friend. Yes, visualization is better. You know, it's just like 2 minutes inflation, camera inside. I can see everything very close. You know that with a suction apparatus, it will be great. But you cannot do this in the exam. They will kill you if you choose laparoscopy in internal hemorrhage because it's against the rules. Okay. Thanks, everyone. I enjoyed, as usual, every moment with all of you. And it was really, I think, a valuable free webinar. Thanks, MedExam, for this free webinar. And thanks all my friends who joined me in this wonderful 1 hour or more than 1 hour. I wish all of you gained the benefit.
See, Dr. Hassan, please, I'm still having problem to contact you. If you can call the number, I'll write it down because when you type, I hardly see it after it wipes off. Can you call it? Let me take it down once now. How to contact you?
Okay, okay, of course. Please write your number. Thank you so much.
Give me the number now. Let me go. Your number, please, sir.
It's available in chat room. This is my WhatsApp. You can message me anytime you want. Thank you so much, everyone. Can I join the progressive course? It started already. Please contact MedExam, and you are very welcome as usual. Thank you. Enjoy your night. Best of luck in your preparation, and keep the good spirit and be smart while you are studying. Smart studying is better than hard working. Believe me. Have a nice night. Bye-bye.